So we have been called to a 75-year-old male with a chief complaint of chest pain. Prior to our arrival, he has collapsed onto the ground. His wife has told us that he has had a previous MI 5 years ago and is currently on Cilazapril and aspirin. First set of obs have come back with a heart rate of 170, blood pressure of 80/40, GCS is currently 121, so a GCS of 4. His respiratory rate is currently at 18, is maintaining his own airway, so we currently have a non-rebreather on him. His VGL is currently 7.6 and he has a temperature of 37. Currently our patient is severely compromised, he is hypotensive, unable to obey commands, and is at high risk of going into cardiac arrest, and he looks status 1, he's pale, cool and clammy. We have currently got the pads attached to the apex and sternum. We have bilateral large bore IVs and fluids running to try and raise the blood pressure. First of all, I'm just going to print off our 12 lead to see what rhythm we are in. So this looks like he is in a VT. So our differentials for VT are electrolyte imbalances, such which can be caused by kidney failure, potassium supplements, use of diuretics, and a recent MI, which is probably suspected here, and also SVT with aberrancy. So now we have got our pads on. I'm just going to make sure that I'm calling for R50 backup. So AUT1 calls comms.
Go ahead, AUT1.
Requesting R50 for status 1 VT.
Copy, they'll be about 20 minutes away.
Copy, thank you. Alright, so we have our pads on. We are currently in manual mode. We have selected lead 2 as it has the most visible R wave and there is no artifact shown. We are now going to press sync to put our monitor into synchronized mode, and we can see a detection symbol over every QRS. So I'm just going to go through our checklist. So we have pads on, we have the defibrillator in manual mode, we have the most visible R wave chosen, as well as the detection symbol over every QRS. Currently our patient does not need sedation as of GCS and unable to obey commands. We are going to turn our monitor to 200 joules. We are going to press charge. And when that's ready, we're going to clear our patient. Shocking now. Okay, shock has delivered. And it looks like we have gone into normal sinus rhythm, so I'm just going to check for carotid. Nice strong carotid. Check for a radial. Still no radial, so we're going to keep our fluids going and get to hospital. Patient still doesn't look like he's regained consciousness, so we're going to just travel fast. We've been called to a 40-year-old male who has fallen 6 meters onto the concrete, query fallen onto his occiput. Upon our rapid trauma assessment, we have found an isolated 6 centimeter boggy patch on his forehead, and currently we've obtained a first set of vitals as a heart rate of 50, blood pressure of 160/90, and a regular respiratory rate of 12, and a GCS of 5 made up of 2 for eyes, 2 for voice and 1 for movement. Now on our rapid trauma assessment we haven't found anything other than the isolated boggy patch. There is no obvious signs of any other trauma or bleeding. We have immobilized the head for an EC spine compromise. Currently our patient is maintaining his own airway, however with a decreased GCS this can obviously become compromised at any point, so we have an OPA and LMA on hand. We have our BVM ready behind us, set onto a peak rate of 5 centimeters of water. Our patient is currently receiving 10 litres of oxygen per minute reservoir mask. We have attached our defib pads, our electrodes for our ECG, our blood pressure monitor and our SpO2. We have bilateral IV access and have some fluids running, treating for querying a TBI currently. We also have morphine for if our patient becomes a bit agitated or combative, to try and control that. With our fall, we want to rule out any other causes. We're currently going with the fall being mechanical, but other causes such as metabolic, our BGL has come back as 7, so we're not concerned for hypo or hyper glycemia. And our temperature is sitting at 37, so ruling out hyper or hypothermia. Our ECG currently shows that the patient is sinus bradycardic, and there's no obvious causes of cardiac involvement currently. So this patient meets RSI criteria, as his GCS is under or equal to 10. And currently our patient may need ventilatory support. So AUT1 cause cons.
Go ahead, AUT1.
Could I please get an RSI qualified R50 for a query TBI?
Copy. They're going to be 10 minutes away and they've asked you to prepare for the RSI.
Copy. Right, so now we can go through our RSI checklist. So we're going to remove this reservoir bag for the moment, and we are going to place the naso prongs in and ready. Okay, and place the reservoir back over the patient. Now, we are pre-oxygenating at 10 litres per minute via our reservoir bag. We have attached our defib pads, electrodes, our blood pressure, as well as our SpO2. Next thing we want is our capnography, which is ready for when we need it. So I'm just going to place it on the chest here so that we don't forget about it. We have our monitor where we can see it, as well as a clear access on the right side of the patient for when the intubation is being carried out. We have 2 large bore IV access and some sodium chloride running, which is as per our checklist. We currently have our patient positioned as well as we can do in the sniffing position, as well as securing either side for query C-spine. We then have our ETT tube holder, which I'm now just going to place underneath the patient's neck. Without trying to move them as much as possible. So that's ready for when our ICP backup gets here. We also currently have our suction unit ready, just in case our patient vomits, and so that we can prevent any aspiration of vomit into the lungs. Like I said before, we have our BVM set up behind me with our PEEP set to 5 centimetres of water. We have obtained our first set of vitals, and we will continue to monitor that in another 5 minutes prior to our ICP's arrival. We will then obviously update our ICP of the patient's condition, which still looks the same, as well as doing another set of vitals. And then as we are in the ambulance, we have made sure that all our equipment is placed nicely and there is no unnecessary clutter area. So now our RSI checklist is complete. We have to be prepared for a failed RSI. So the ICP is allowed 2 attempts before stopping. So therefore we then have either an OPA, MPA or LMA to ventilate the patient with our bag valve mask. During the intubation, the ICP may ask for the burp assistance. So applying backwards, upwards and rightwards pressure on the trachea. Also, the ICP may need assistance with a bougie to find the anatomical landmark and place that in to then feed the ET tube over. And then finally, they may need assistance with a failed RSI to do a cricothyroidectomy and to make sure that this patient has an adequate airway. Obviously, we would then get this patient continuing on to hospital and given our early R40 to the responding hospital.